Today, we're doing something really cool. We are mapping out the ultimate road trip. We're going to trace the literal and figurative journey of a single heartbeat. You know, the complex path of blood flow through the human body is, well, it's an absolute masterpiece of biological engineering. It's this non-stop logistical marvel that literally keeps us alive, and we're going to break the whole thing down step by step. But first, I want to hook you with a number that just completely blew my mind. 60,000. We are talking about 60,000 miles of blood vessels inside your body working around the clock. To put that into perspective, if you took your body's internal highway system and laid it out end to end, it would wrap around the Earth more than twice. It's just a massive, intricate network built for constant, high-stakes delivery.
Now, what's really interesting here is the sheer density of routes required to pull this off. This massive arterial highway network circulates about 5 liters of blood to and from literally every single functioning cell in your body. It never stops, it never takes a break, and it's meticulously organized to make absolutely sure that oxygen and nutrients reach their exact destinations precisely when they're needed.
All right, every great road trip needs a starting point, right? So let's head into Section 1 and meet your mighty heart, the literal engine of life.
Before we get into exactly what it does, let's talk about where it lives. The heart is a hollow, muscular organ, roughly the size of your closed fist, and it's perfectly situated in the mediastinum. That's the central compartment right there between your lungs. It sits behind and just a tiny bit to the left of your sternum, spanning the area from your second to your fifth intercostal space. So right between your ribs. It's tucked in super safely behind that rib cage, just perfectly positioned to pump blood out to the rest of the body. Let's break down the actual anatomical machinery here, because this is where form brilliantly meets function. First off, the whole thing is protected by a thin sac called the pericardium, which holds just a little bit of serous fluid to cushion the heart and keep friction down while it beats. Inside, it's divided into 4 chambers. You've got 2 upper atria, and these have really thin walls because they mostly act as holding reservoirs for incoming blood. They just give it a gentle little boost down into the lower chambers. Now, those lower chambers, the 2 ventricles, those are your thick-walled, heavy-duty pumps. And this is absolutely crucial. The left ventricle's wall is actually 2.5 times thicker than the right. Why? Well, the right side only has to push blood right next door to the lungs. But that left ventricle, it is pumping iron. It has to push against way higher pressure to send blood all the way down to your toes and back up again.
Which actually brings us perfectly to Section 2, the path of blood flow. Let's trace that cardiac circulation.
Okay, let's dive into this and imagine a single drop of oxygen-depleted blood returning from a long trip around the body. First, it arrives back at the right atrium via the superior and inferior vena cava, along with the coronary sinus. From there, the right atrium drops that blood down into the right ventricle. Then, boom, the ventricle contracts, the blood gets ejected out through the pulmonic valve, into the pulmonary artery, and heads straight for the lungs to pick up some fresh oxygen. Revitalized and oxygen-rich, it travels back to the heart, sliding into the left atrium through the pulmonary veins. Finally, the left atrium dumps into that thick, muscular left ventricle we just talked about, which gives a massive, powerful squeeze, pumping the blood out through the aortic valve, into the aorta, and out to the entire body. And remember, this continuous, overlapping cycle happens rhythmically with every single contraction. So you have the blue, deoxygenated blood moving through the right side to the lungs. At the exact same time, the red, oxygenated blood is moving through the left side out to the body. It's an incredibly precise, synchronized flow.
But with all this forceful squeezing and high-pressure pumping, how does the body prevent wrong-way driving on this highway? Well, that brings us to Section 3, one-way valves in action. To keep all this traffic flowing strictly in one direction, the heart has its own built-in traffic control doors, its valves. You've got the atrioventricular valves between the upper and lower chambers. That's the tricuspid on the right and the mitral on the left. Then you have the semilunar valves guarding the exit ramps, the pulmonic and the aortic. Now, these healthy valves open and close completely passively. It's all based on pressure changes in the chambers. And to make sure they don't blow backward under the extreme pressure of a heartbeat, their leaflets are anchored tightly to the heart wall by these tough, fibrous little cords called chordate tendinea.
So the really crucial part is how these valves interact with the heartbeat itself, the cardiac cycle. The cycle has distinct phases. First up is diastole. Think of this as the slow, relaxing phase. The heart muscles relax, the chambers peacefully fill up with blood. And then action. Atrial systole. The upper chambers contract. Immediately after that, the pressure spikes in the lower chambers, and those mitral and tricuspid valves snap shut. That forceful snapping shut, That actually creates the very first heart sound you hear in a stethoscope. It's known as S1, the lub. Right after that is ventricular systole. The thick lower ventricles contract, ejecting the blood. As they finish squeezing, the aortic and pulmonic valves snap shut to prevent any backflow. And that creates the second heart sound, S2, the dub. Lub, dub. Lub, dub. Seriously, if you feel your own pulse right now, you are feeling the literal pressure wave generated by that incredible rhythmic snapping and squeezing.
Now, what keeps this mechanical pump running perfectly on schedule? Let's look at Section 4, the electrical control room.
The heart actually relies on its own internal electrical pacing system to build that perfectly timed rhythm. The spark starts way up at the top in the SA node. That's the heart's natural pacemaker. From there, the impulse travels through the upper chambers to the AV node. Then it speeds down the center divider of the heart through the bundle of His, splits into the left and right branches, and finally spreads all the way out into the Purkinje fibers wrapping around the ventricles. This exact, specialized electrical pathway guarantees that the heart contracts from top to bottom in a perfectly coordinated, life-sustaining rhythm, every single time.
Okay, so once the blood is powerfully ejected from the heart, where does it go? Let's finally leave the departure terminal and explore Section 5, the body's highway system, focusing on arteries and veins.
Our peripheral vascular system is highly specialized, and it's primarily split into arteries and veins. Think of arteries as the high-speed delivery highways. They carry blood away from the heart, and because the blood here is under immense pressure from the heart's pumping, arterial walls have to be super thick and muscular. Now, nearly all arteries carry oxygen-rich blood, with the one quirky exception being the pulmonary artery. Veins, on the flip side, are the return routes carrying blood back toward the heart. The pressure is way lower here, so their walls are thinner, a lot more pliable. In fact, veins act as a massive reservoir for circulating blood. And to fight gravity on the long trip back up, from say your legs, veins actually have their own built-in one-way valves spaced out along the way. Again, mostly oxygen-depleted blood here, except for the pulmonary veins coming back from the lungs.
But the real magic? That happens at the very end of the road. Nestled right between the arteries and the veins are the capillaries. If arteries are the massive interstate highways, capillaries are the tiny local neighborhood streets. Arterioles control the blood flow directly into these capillary beds. The walls of capillaries are so thin, so highly permeable, that this is where the actual exchange occurs. Oxygen and nutrients easily slip out to feed your cells, and cellular waste products slip right back in to be carried away. Then these tiny vessels, called venules, gather all that depleted blood back up to start the long journey home via the veins.
I absolutely love a quote from the source material here. It says, "Talk about action. The cardiovascular system is chock full of it." It just injects a bit of fun into a highly complex topic, and honestly, it couldn't be more true. From the electrical sparks in the SA node, to the thick muscular squeezing of the left ventricle, to the rapid snapping of the valves and that high-speed transit across 60,000 miles of vessels, it's a system entirely defined by constant dynamic action.
We're diving right into the precise, step-by-step investigation of the cardiovascular system. You know, when you go in for a physical, it might just feel like a lot of random poking, prodding, and listening. But there's actually this incredibly structured, escalating methodology at play. We're going to break down exactly how clinicians assess heart health, basically decoding the subtle clues your body leaves behind. Let's dive in. So here's our diagnostic checklist, the exact highly organized roadmap clinicians use to evaluate your heart. Right, starting off with Section 1, the general assessment. Now, throughout this whole process, doctors are relying on this escalating sensory investigation. First, they inspect, so just looking closely with their eyes. Second, they palpate, using their hands to feel for abnormalities. Third, they percuss, tapping on the body to listen for resonance or dullness. And finally, they auscultate, which is using a stethoscope to listen to those internal sounds. It's a completely methodical escalation, right? We go from looking to feeling to tapping to listening. During that very first inspection phase, your general appearance actually offers immediate visual clues. The clinician is noticing your weight, anxiety levels, and skin color. Like if a patient is dark-skinned, they might inspect the mucous membranes for pallor. But one of the absolute most fascinating physical clues is what we call clubbed fingers. That's where the ends of the fingers literally bulge out and the nails curve around. This specific visual marker is a direct sign of chronic hypoxia. Basically, it means a lengthy cardiovascular or respiratory disorder has been depriving the body of oxygen over a really long period. Inspecting neck vessels. Did you know clinicians can actually evaluate the pressure inside the right side of your heart without ever making a single incision? It's pretty wild.
By placing a patient in a supine position, elevated right between 30 to 45 degrees, they can examine the internal jugular vein. They take a flashlight and shine it horizontally right across the neck to create shadows, and that highlights the venous pulse. They just find the highest point of pulsation and measure it against a bony landmark on the chest called the sternal notch. It's just such an ingenious, completely non-invasive way to measure right atrial pressure. Okay, next, the clinician is going to lightly place the bell of their stethoscope over the carotid artery in the neck. Now, normally, you shouldn't hear any vascular sounds here at all. But if the clinician detects this distinct blowing, swishing sound, they found a bruit. The crucial takeaway here is that a bruit indicates turbulent blood flow. Think of it like a smooth river suddenly hitting jagged rapids. This turbulence is frequently caused by arteriosclerotic plaque forming inside the artery itself. So it's a really critical auditory clue picked up right there at the neck. Chest. The human chest is basically a landscape, and clinicians use a very specific topography to navigate it. They identify imaginary lines, like the midclavicular line, and they actually count the spaces between the ribs so they know exactly what part of the heart lies right beneath. One really key target is the apical impulse. That's the heart's maximal point of impact against the chest wall. Doctors use these landmarks to find this specific spot, usually at the 5th intercostal space, right near that left midclavicular line, literally so they can physically feel the heart beating against the chest. So when the clinician is feeling or palpating the chest wall, they're searching for two very specific tactile clues: heaves and thrills. A heave is, well, exactly what it sounds like. It's a strong, visible outward thrust of the chest wall that happens when the heart contracts during systole. A thrill, on the other hand, is a much, much finer sensation. If a clinician feels a thrill under their fingertips, the source material describes it as feeling exactly like the fine purring of a cat. It's this palpable vibration that tells them something is disrupting the normal flow of blood.
And that listening to the heart.
Now, clinicians don't just slap the stethoscope down randomly. They trace a very deliberate, distinct zigzag pattern right across the chest. They start at the upper right for the aortic area, move straight across to the upper left for the pulmonic area, slide down to the lower left sternal border for the tricuspid area, and then finally move outward to the mitral area at the bottom. This specific path lets them isolate the different mechanical blood flows at 4 specific valve sites, so they can listen intently to the totally unique story each one is telling.
We all know that classic lub-dub sound of a heartbeat, right? But what exactly is making that noise? Well, the lub is the first heart sound, or S1, and it's literally the physical sound of the mitral and tricuspid valves snapping closed as the heart squeezes during systole. The dub is S2, which is the aortic and pulmonic valves snapping shut, right at the end of that squeeze. But remember, our medical detectives are also listening really closely for extra adventitious sounds during diastole. We're talking about things like an S3, an S4, or vibrating, rumbling murmurs. These extra sounds can reveal absolutely crucial structural clues about the heart. And to hear those extra sounds, doctors actually use gravity and positioning to their advantage. They'll systematically listen to your heart in 3 different positions. First, lying back at an angle. Then they'll have you roll onto your left side. That's the left lateral recumbent position. And that's the absolute best way to catch low-pitched sounds in mitral valve murmurs. Finally, they'll ask you to sit up and lean forward. Why? Because it literally brings the heart closer to the chest wall, making it so much easier to hear those high-pitched aortic murmurs. Now, sometimes a clinician is going to hear this scratchy, rubbing sound through the stethoscope. It's known as a friction rub. But here is the real detective challenge. Is that rubbing sound coming from the lining of the heart or the lining of the lungs? To figure it out, the clinician uses a brilliant but super simple trick. They just ask the patient to exhale and hold their breath. If the scratchy sound stops, well, it was the lungs. But if you're holding your breath and that scratchy, rubbing sound is still going, that proves it's a pericardial friction rub, perfectly timed with the beating of the heart itself.
The vascular system. They kick this off by assessing peripheral blood flow using a brilliantly simple method called the capillary refill test. Basically, the clinician presses down on your fingernails or toenails until they turn white, then lets go and watches just how fast that pink color returns. This refill time should take absolutely no longer than 3 seconds. Actually, a great rule of thumb from the source material is that it should only take as long as it takes to say the words capillary refill. If it takes longer than that, it's an immediate flashing clue that peripheral blood flow is compromised. After that, the clinician methodically traces the vascular highways of your arms and legs. pressing on specific pulse points. They'll check the radial pulse right at your wrist and the femoral pulse down at the crease of the groin. But get this, they aren't just feeling these pulses to calculate your heart rate. They are actually comparing them side by side. They want to ensure the pulse volume and the symmetry are totally equal in strength on both the right and left sides of your body. That guarantees the blood is flowing evenly everywhere. So think about it. We've gone from looking at the color of your fingertips to shining a flashlight across your neck to feeling for the purr of a cat on your chest wall, and finally, tracing a zigzag path to decode the mechanical snaps of your heart valves. The human body is constantly talking to us, and when it comes to the heart and blood vessels, spotting those abnormal findings right away is absolutely crucial for catching serious underlying conditions. So let's focus squarely on how to spot these cardiovascular abnormalities. Here is our game plan for this outside-in assessment. Visible clues, skin and ulcers. We always begin our investigation right on the surface of the body with what we can see immediately. The skin tells a huge story about tissue perfusion and cardiac output. Notice how distinctly the body contrasts these two issues. With arterial insufficiency, meaning insufficient blood flow out to the tissues, the skin gets pale, cool, and shiny, often with hair loss. And those ulcers, they typically pop up right at the very distal ends, like the tips of the toes. On the flip side, chronic venous insufficiency, driven by venous hypertension, presents totally differently. You're much more likely to see brown pigmentation, and the ulcers usually sit higher up, right around the ankle. Feeling for fluid, assessing edema. So now we go from what we can see to what we can physically feel beneath the skin. Specifically, we're talking about swelling or edema, which is a classic red flag for heart failure or venous insufficiency. The absolute key here is figuring out if you're dealing with pitting or non-pitting edema. With pitting edema, applying pressure actually forces fluid deep into the underlying tissues, leaving this visible little indentation that fills back in super slowly. But with non-pitting edema, that fluid is actually coagulated. Pressure won't leave any indentation at all, and the skin itself is going to feel remarkably tight and firm. And here's a brilliant, quick 3-step bedside check to grade that pitting edema. Step 1, just press your finger firmly against the swollen area for 5 seconds. Step 2, quickly pull it away. And step 3, simply estimate the depth of that indentation in centimeters. That lets you assign a clinical severity grade, anywhere from a mild 1+ all the way to a severe 4+. The pulse waveforms. We are transitioning now from feeling static, built-up fluid to feeling the dynamic, rhythmic waveforms of the pulse. This tells us incredible things about cardiac output. Take a weak pulse waveform, for example. It's got a decreased amplitude with a very sluggish upstroke and downstroke. When you feel this under your fingers, it's often pointing straight to increased peripheral vascular resistance, like in severe heart failure, or a decreased stroke volume from things like hypovolemia or aortic stenosis. Now, completely contrast that with a bounding pulse. This one features a really sharp upstroke and downstroke with a distinctly pointed peak. The amplitude here is way up. That typically means an increased stroke volume, maybe from aortic insufficiency, or it's just highlighting the natural stiffness of aging arterial walls. Now we get into some truly wild patterns. Notice this regular alternating rhythm. Strong beat, weak beat, strong beat. This is pulsus alternans. If you feel this, pay attention because it is a classic, highly specific hallmark of left-sided heart failure. At first glance, pulsus bigamenus looks kind of similar to what we just saw, but watch the timing. Those alternating weak and strong pulses are happening at irregular intervals. This specific irregularity is usually triggered by premature atrial or ventricular beats, just totally disrupting the normal cardiac cycle. Here's a really fascinating one, pulsus paradoxus. The pulse amplitude actually dips every single time the patient breathes in. That marked decrease during inhalation is a major warning sign. It is heavily linked to things like pericardial tamponade, advanced heart failure, and constrictive pericarditis. Finally, we have pulsus bifurcans. This waveform shows a distinct double upstroke during systole. So you get an initial peak, a slight dip, and then a second peak before the cycle even finishes. It's highly unusual and typically points to aortic stenosis and aortic insufficiency. Listening to heart sounds. It is time to decode the auditory clues hidden in the chest. Listening closely reveals exactly how the heart's chambers and valves are struggling. To conceptualize these rapid extra sounds, just remember these phonetic rhythms. The Kentucky rhythm is your S3 ventricular gallop. It's a low-pitched sound when ventricles fill rapidly, and in adults, it's a cardinal sign of heart failure. Then you have the Tennessee rhythm. That's the S4 atrial gallop.
It happens right before a normal S1 and indicates a stiffened ventricle resisting filling, something you'll often hear in patients dealing with hypertension or aortic stenosis. And if you ever put your stethoscope down and hear this high-pitched, scratchy, leathery noise, literally like two pieces of sandpaper rubbing together, that is a pericardial friction rub. It's the classic auditory sign of pericarditis, an inflamed pericardium, which can pop up from infections or radiation therapy.
Finding murmurs and brutes. For our final diagnostic layer, we are looking at murmurs and brutes. We categorize murmurs using a standard 6-level scale based on intensity. It scales all the way from grade 1, which is barely audible even to a highly trained ear, up to a grade 4 where you can literally feel a vibration or a thrill right on the chest. And it peaks at grade 6, which is so incredibly loud you can hear it with the stethoscope completely lifted off the chest wall. But aside from just volume, you also have to track the shape of the sound over time using these configurations. A crescendo murmur gets progressively louder. A decrescendo gets softer. A crescendo-decrescendo murmur is diamond-shaped. It smoothly peaks and then fades. And a plateau-shaped murmur just stays totally equal in intensity. Tracking these shapes is how you pinpoint exactly which valve is failing.
Just remember, not every swishing sound actually comes from the heart. If that murmur-like sound is originating from a blood vessel, like say the carotid artery, you are actually listening to a brute. So the next time you assess a patient, keep this explainer in the back of your mind.